on their cameras, it's generally a much nicer experience if everyone can see who they're talking to. So if you want to do that, it's the start video icon, which again is in the menu down the bottom left. Yeah, brilliant.
Yeah, that's brilliant. Thanks, guys.
So I suppose Shanti or Padma, Shanti, do you want to give just an overview of kind of why you came on the program and how you found it, what your background is and kind of how you found what's been almost a year at this stage that you're on it?
Okay. I work in a GP clinic for a corporate company in an area which is mainly an industrial area. So the type of patients, the crowd of patients that I get are generally middle-aged and a little bit on the elderly. So I get a lot of patients who are diabetic. So they tend to ask lots of questions about how do we handle diabetes by minimizing medication, or are there any programs that we could join for like diet programs and things like that. So, and that was when this came about in the MMA. So I thought it'd be useful for me to join and to be able to help out my patients more, to get a better, more detailed insight about diabetes, not just medication, but an overall approach to it. Yeah, and 1 year has flown by so fast.
Absolutely. And how have you found the format of the program and kind of fitting it in around kind of clinical life and family life and anything else that you might want to do, like have a social life?
Yeah, I mean, I was able to squeeze everything in a little bit here and there, but it wasn't too bad. Well, timings were in the evening, so it was adjustable with clinic work.
Yeah. And do you find that, even going through the program, obviously you're almost at the end of the postgraduate diploma piece now, do you find that it's changed how you're managing patients?
Oh yes, very much so, very much so. I'm actually able to detect cases very much earlier, like in the pre-diabetic stage, not like before, and actually able to counsel patients even more better in detail and to their level of understanding, not too scientific.
Yeah, make it relatable to them and try to empower them to kind of take responsibility as well. And when, I suppose, one of the things we look at when we do the pre and post surveys in the program is kind of confidence levels around various things. And a lot of people that come onto the program, they're nervous about injectables. They're nervous about kind of how to manage the patient on injectables. They're nervous about kind of stepwise intensification of treatment when it is needed. How have you found those things?
Well, convincing a patient to start on the injectables is very difficult. Even now, I have the difficulty because no one wants to prick themselves. Yeah. So what I do is I just tell them, okay, fine, we will do your dietary and lifestyle changes, and then we'll see how it goes for a couple of months. If it doesn't work, then we'll try oral. If that doesn't work, then we'll have to go in for injectables. So I do go step by step, and I explain to them, okay, I'm giving you a chance to do what you can do, but if it doesn't work out, you're going to have to meet me halfway.
Yeah. Yeah. Brilliant. Yeah. And I suppose in terms of a return to study, one of the things I'm always conscious of is, the average age of people on this program is early 40s. And, there's a normal distribution around that. But, for most people, it's a fairly long time since they've done anything academic, since they've sat down and, written an essay or studied.
Yes, very true.
Sense. How did you find that adaptation and, welcoming back into that type of world of reading journals?
It was very difficult initially. I mean, we had to read the journals and we had to sit down and compare so many types of journals to actually concise everything into an essay. But we got pretty good guidance from lecturers whenever we emailed them and asked them questions about it if we had any doubts. So I found that pretty helpful.
Yeah, and I think one of the things that we see, I think you're absolutely right. Everyone finds the first essay challenging and even the second one, but they get into a rhythm and you get very used to it. And what we always look at is the average the average marks on the essays between, say, a module 1 or a 2 essay, or a module 5 or 6 essay, like, they're unbelievable. The difference in standard that you're producing by the end of the program compared to the start, and you know, and that is a natural journey.
Yeah, because we already know what to expect by the end of it.
Yeah, exactly. No, good that you're not kind of fearful of it. The final thing I was going to ask is, you know, this course is steeped in kind of the chronic disease, the chronic care model of management. Do you see elements of the program applicable to other patients that you have that, you know, might have COPD or something else, or cardiovascular issues?
We actually can only handle to a certain extent where my work setup is just a GP clinic. If I thought we have anything more than that, we always end up referring them off to a tertiary center or the government hospital. There's only so much that we can do.
Yeah, absolutely. No, that makes perfect sense. Okay, well, I think, you know, that I hope that gives everyone, you know, we're going to give obviously a bunch of information on the program itself, but I hope that gives people a sense of, you know, what it's like to be a student in terms of balancing it with your clinical load, with your family life, etc., and the you know, the types of experience that you'll have on it. Rebecca, do you want to jump in?
Yeah, thank you so much, Shanti. And if you don't mind, if you could stay in the session, just in case any of our participants have any questions for you, that'd be brilliant. There'll be a Q&A session at the end, guys. Just another piece of, because there's a few more people I noticed who have joined us, and just I'll repeat myself that on the bottom left-hand corner of the screen, there's a mute button. So at any time, you're automatically muted when you enter, but if you want to ask a question at any time, you're very, very welcome to do so. So you can unmute yourself. And also, it's a much nicer experience if we can see your face. So you're very welcome to put on your camera. So the video button is right beside your mute button on the bottom left-hand side of the screen. It's just a nice experience if we can all see each other. You don't have to, but it's nice to see you. But without any further ado, I'll hand you over to Dr. Letchuman, who'll give an overall presentation about diabetes and what to expect on the program. So thank you.
Letch, I think you're on mute there.
Oh, okay.
Yeah, brilliant.
Yeah. Hi, everyone. Nice to meet you. And this is the only way we can meet during this MCO. So it's a very apt that we are on to this Zoom quite early. And I'm using Zoom a lot now out of no choice.
Yeah.
for a lot of my meetings. So my name is Letchuman, and I work as a physician in Hospital Ipoh. I came on board on this as a facilitator about a year ago, I believe, and I've had about 3 or 4 groups that I've taken. So I'm just going to give you an overview of the state of diabetes in our country, and also mention how this chronic care model of management is important in us tackling diabetes in our country. So you will see the slides.
It's not sharing yet. Oh yeah, there we go. Yep, perfect.
And so these slides, I've got it from Dr. Faizul, who is the in the non-communicational disease section of Ministry of Health. So this slide shows us the proportional mortality in Malaysia. And this is a pie chart of 146,000 deaths when it was analyzed. You will notice that about 73% of it is due to non-communicable diseases. That is cardiovascular disease, cancers, chronic respiratory disease, diabetes, and other NCDs. So in our country, like in most first world countries, we are going towards non-communicable disease as a cause of mortality. And if you see this by risk factors, what risk factors give rise to the deaths? A major portion here is both in males and females is high blood pressure, followed by tobacco use, smoking, and that's of course higher in our male population. But hopefully over the next 10 years or so, I hope that this will reduce with us having stringent measures on reducing smoking in our country. We started about 2 years ago. Diabetes next, then high cholesterol, high BMI, physical inactivity. So if you think about it, a lot of morbidity and mortality in our country is due to this common risk factors which we can do something about. Next slide shows what we have been shown many times, that the rate of diabetes is doubling every 10 years almost. And the frightening thing is half of them are unknown. So this was based on National Morbidity Mortality Surveys, where you go out to the community to measure their blood levels, and it's rising. In fact, if you take the 2020, the results are even higher. So diabetes is getting more. And what's the cause of diabetes? It's estimated that in Malaysia, it's about 16% of our national healthcare budget. And in absolute terms, in 2010, 2.4 billion was used on diabetes-related healthcare. So we are among the top 10 countries with a high budget on diabetes. So with regards to the absolute number of diabetics in our country is estimated to be about 3.5 million. We have a registry within the Ministry of Health for patients who come to the clinics, the primary care clinics, or what we call the Klinik Kesihatan. And in this registry, in 2017, there's already about 1.4 million patients registered. So the data that I'm going to show subsequently is from this registry. So it's a big registry. So these are the average HbA1c levels by state. If you look at the overall average for the country, we are about 8. And this has not changed from 2013 to 2017. So that's something that we must do better. So this is the number of patients whose HbA1c reaches less than 6.5. And again, you notice that it's a decimal figure. Most of it is less than 30%. In fact, some less than 25%. The Malaysian average is 23.5%. So we're not doing very well in terms of HbA1c, reaching HbA1c targets. But we are not too bad in the processes. That means what needs to be done at every visit. For example, taking the blood pressure about 93%, taking the weight 91%, calculating the BMI quite high. We may be low in doing the eye examination and the ECGs, but rest of it, we're doing not too bad. So the processes, we are okay, but not the targets reached, not the outcomes. So again, these are the targets. The HbA1c, as I showed you earlier, is still low, even BP. Maybe the lipids are easier to control, so the HDL that's achieved is about 70%, but the rest of it, we are not doing too well. In terms of complications in primary care, and this is not secondary care. Secondary care, the rate of complications are higher because those patients with problems are referred to tertiary care. Retinopathy already present in 9.6% of patients, ischemic heart disease 5.1%, cardiovascular disease 1.5%. Again, take note, this is primary care figures. Nephropathy already in 11.5%, diabetic foot ulcer in 1.3%, and amputation already in 0.7% of that. So, could we do better as a nation is something that we need to ask for diabetes. 30 years ago, we patients tend to present late, and then we're always catching up on targets. And the drugs were just metformin, Dianyl, and 2 types of insulin, Actrapid and Insulatard. Usually it's managed by one doctor, and then the doctor refers when complications arise. But currently, I think the push is to screen early. And I think this is where primary care becomes so important. You guys see patients as a whole family. The middle age, those working may bring their parents or their children to you, but you may want to see the middle age to see whether they are okay and screen them early for diabetes. Because you will soon see if the evidence shows that if you detect early and you keep them well, it's easier to keep it at targets, and hence they will have definitely less complications. So this is what the next one, keep them below targets, not always catching up from behind. And in terms of therapeutic agents, it's no longer just 2 or 3. There are 7 oral categories already, and there are several types of injectables already available. So it's important, I think, to keep in touch and also manage together with other disciplines. You will notice that you will need the help of the ophthalmologist, the orthopedic surgeon, perhaps a physician, the endocrinologist, the physiotherapist in some instances when there's complications, the dietitian, the pharmacist. So there are many specialties that need to work together to manage these patients. But even though it's multidisciplinary, it must be patient-centered. And hence, the primary care physician is the most apt doctor to be the focus point, where you will get help from multidisciplinary units when needed, but you take care of a patient. The final call is yours. So all of this multidisciplinary comes around the patient, which is coordinated by you. I think that's extremely important. And those is one of the features of this chronic care model. Chronic care model relates to ambulatory care, and as the name suggests, is focused on improving the care for patients with chronic disease, and diabetes is a very good example. And there are certain facets or certain principles in this chronic care model. And one of it is improving the skills of healthcare professionals. And I think you know that this is important. We all know from the first day we became doctors that we need to keep improving ourselves. And I think that's why you've joined this session, to see whether this will be useful for you. And we need to work in teams. You'll probably be the person who will be coordinating between the various teams that may be available around you. And then there may be strategies that you would have on hand, and in the I8 system, this is provided as well. Strategies, pamphlets, booklets to educate and support patients. And also health information systems, including local registries. That's why I mentioned the registry earlier within the Ministry of Health. So they use that to improve care. Perhaps we should include the primary care physicians as well. And this is going forward. So you'll know where the patients are, what kind of patients, who's not controlled, who's controlled. So pay attention to those who are not reaching targets. So if this is done in a form of registry using the latest technology, databases, I think we can identify where the problems are. And then the decision support mechanisms. You can be assured at least for the next 1 year, you will have this decision support mechanism to some extent. You can ask questions about your patients, but eventually you need to have a system within where you are to, when there's difficulties from multidisciplinary teams to support, to manage your patients in front of you. We need to have mechanisms. Now, has this ever been done in our country? It may look foreign to us, but actually there was a study called the COFFEE study, which was community-based cardiovascular risk factors intervention strategies in managing hypertension. I think this took place about eight years ago, and I was involved in the preliminary planning stage. This is again using the chronic care model where there was algorithm, a plan, there was support for the GPs. They were given sort of instructions or CME on how to manage hypertension, but there's also support. And there was a registry to see, hey, this is not done yet, this is lacking, and so on. So what are the results of this coffees? And all those doctors who took part were general practitioners with their patients. So what they found was the proportion of hypertensive patients who achieved target BP at 6 months was significantly higher in the coffees arm, that is the interventional arm, 70% as compared to the control arm, which was just 57%. So in other words, it does work to some extent, and this was in Klang Valley. It was done in Klang Valley. So final conclusion was patients who received the coffee care demonstrated significant improvements. Lately, there was another attempt to see whether this chronic care model is feasible in the Malaysian public primary care setting. And I think this was a group from UITM. And they concluded that the implementation of the essential component of CCM is feasible in public primary health centers despite various constraints. So I think diabetes is a major problem in our country, not just because there's sweetness in the plasma, but because of the complications. We are seeing a lot of patients with amputations, ischemic heart disease, strokes, which is related to the diabetes. And primary care focus, I think, is the way to overcome this. So I'll end here. I'll be very happy to take any questions if there are. If there are none, I'll hand back to Rebecca. Rebecca, do you want me to be on, or could I go off? Because I probably have a lot of WhatsApp messages by now.
No problem, Dr. Letchuman. If you need to go, that's no problem.
Thanks so much, Letch. Really appreciate it.
Thank you. Good session. Good night. Good night.
So everyone, that's just to give you a sample of Dr. Letchuman, one of our leading academics on the programme. Just an example of what you'll be experiencing every week in your tutorials in the Zoom session. So what I'll do now is I will just share screen and I will go through the programmatic overview of the programme myself. And once again, apologies for the repetition, but I noticed that some other people have joined us a little bit later. If you at any time have a question to ask, you have a mute button on your bottom left-hand side of your screen and you can unmute and ask us any questions. And you also have a video button beside the mute button. And you are very welcome to essentially just put on your video so we can see you, because it is a nicer experience. And if you do come on the program and you're doing your tutorial, we do ask that you always turn on your video as well. So it's nice to see each other. Also, one of our staff members, Quiva, she is online with us as well. And she will be just asking you if you have a name that isn't obvious, rather than your full name, like iPhone or iPad or Huawei, she will be asking you via chat for your real name so she can log you in online. So with that, I will just go now to present to you guys, and make sure, just let me know if you can see the screen. Now, can you all see that?
Yeah.
Yeah, super. Right, so this is just a programmatic overview for what to expect from the programme. So, of course, this programme is accredited by the University of Warwick, but you'll hear us mention the word and term IHEED again and again and again. So who are IHEED and how do we relate to the University of Warwick? We're an online programme manager. We're an Irish company. We serve ministries of health and governments worldwide, and we're the online program manager for this program from the University of Warwick, but also work with world-ranking universities and professional training bodies throughout the world. We do have a focus on primary care, and we do have a lot of family physicians and general practitioners on our programs. But having said that, we welcome And I suppose we very value IPE, which is interprofessional education, and we welcome all of the full transmural care team on this diabetes program. So we also have pharmacists, we have nurses, we have endocrinologists, we've cardiovascular surgeons. We've had a huge mix, and that's very, very important because, you know, when you are training and upskilling in any NCD, the full team working from the same hymn sheet and talking to each other and understanding and being educated together is hugely beneficial. So even though there is a focus on primary care, and we have I would say a social mission to take some of the weight of NCD management away from tertiary and secondary care and into primary care, where it absolutely belongs in terms of early intervention and prevention and screening, but we do welcome all from across the whole transmural care team. IHEED itself has over 300,000 course completions and over 30,000 clinicians registered on our programs globally. So we have a very large footprint, even if you haven't heard from us. And we have a wonderful relationship with the Ministry of Health in Malaysia as well. And we run a program with the Ministry of Health in Malaysia and RUMC in a family medicine training program. So it's the Irish Malaysian Family Medicine Training Program in Malaysia, and that is very successful. So you might have heard about that as well. So just moving on, the University of Warwick are our accreditors for this program. They are extremely prestigious. They're top 10 in the UK, 54th in the global world rankings. 14,000 diabetes graduates have come out of the University of Warwick. So as such, they would have a very long and illustrious tradition as a diabetes educator university, and they're very well known and will be the #1 in the UK for diabetes education. They're a member of the very prestigious Russell Group, which are the leading research universities in the United Kingdom, including Oxford and Cambridge, etc. So the top research universities in the United Kingdom are part of the Russell Group. And as I said, they're world leaders in diabetes education, and they fully accredit the program. So when you get your certificate from us, nowhere on the program does it say, on your certificate does it say this is distance learning or blended learning or anything like that. You get the exact same qualification as if you were to fly to the University of Warwick and spend the year or two doing the postgraduate diploma and MSc. So you are at no disadvantage whatsoever in your certificate. It is the exact same. So it is a 12-month program if you choose to do the postgraduate diploma, and it's an additional 8 months if you want to do the Master of Science. So it'll be 20 months in total for both the postgraduate diploma and the MSc combined. It's developed specifically for Malaysia and the Middle East regions. So we don't just cut and paste the exact same program content across every region. When we are going into a country, we nuance and bespoke everything. Our tutorials, as you see, Dr. Letchuman there is from Malaysia. Our staff are mixed with global experts, renowned diabetes experts globally, and also local experts, because we understand that there are very specific nuances to every single region, and we're very sympathetic to that. Understand that one size does not fit all. So that's something we pride ourselves on. We've full international accreditation, as I said, by the University of Warwick. We're recognised and we are in partnership with the Malaysian Medical Association in Malaysia, which will give you your CME recognition. And they're also our partner in the region. We're also a close partner with the MOH and NADI. And you get full CPD, as I said, our CME from the MMA. Designed and delivered by world-leading diabetes experts and delivered on the world's most advanced medical education platform. When I first saw that sentence at the bottom, I was a bit embarrassed. I thought it was a bit boastful, but I've worked in education for nearly 20 years, and I genuinely haven't seen an online platform that is as easy to use, as palatable. It's just putting very complex information in a very digestible format. And it's just so easy to navigate, and there's everything from 3D videos, hot topics, quizzes, you know, your online tutorials, your workshops. It is very, very interactive, and it's nowhere near that terrible tired distance learning where you're left to yourself just to learn by yourself and you're very isolated. We pride ourselves in an awful lot of touch points with our students. So you will have so many times to reach out and be with us on a weekly basis. And it's very engaging. So there's no such thing as those downloadable PDFs and talking head videos. It's very, very interactive, and you will understand that if you come on the program. And as I said, the faculty are a mix of local and international experts. So you can see the program director is Dr. Colin Kenny. He is a past chair of the Primary Care Diabetes Society in the United Kingdom. He has a Medal of the Empire Award for his contribution to diabetes in the community. And so he's really, his love and his passion is diabetes care. Dr. Mark Kennedy is one of our Australian clinicians teaching on the program, and he's founder of the PCDS in Australia, the Primary Care Diabetes Society, and director of Choreo Diabetes Clinic. Katie Reid is in the University of Manchester, and she's a clinical education expert and would be considered an expert in, I suppose, clinical change in our patient behavioural change in a clinical environment. And Dr. Stephen Lawrence is senior diabetes lecturer in the University of Warwick, advisor for Diabetes UK and clinical diabetes lead in the RCGP. And Dr. Mohammed Fargali, which is in Dubai Healthcare Authority, and he would be considered one of the foremost experts in diabetes in the whole of the GCC. So we have an illustrious faculty which is growing all the time, both national and international and local to your own country, and it's really important to have that mix. So what does the program mean for you? We, even though we're online and distance learning, we don't just take as many students as possible. We absolutely limit the number of students who can do our program. We do that intentionally so that you can be guaranteed a lot of individual care. So we have 20 participants per group, and if it goes beyond that, we do split it up. So you do get an awful lot of attention from our academic affairs team. There's 6-by-6 week modules that are very well placed. We do break for religious festivals like Ramadan, and we're very sensitive to the local religious festivals. And you have a 2 weeks gap in between each module as well, where you will get a chance to recuperate, but also submit your essay or assignments. We have a personal commitment. We do say it's around 10 to 15 hours per week for the program. Now, when I'm giving this presentation in a seminar setting, I usually hear an audible gasp from the room when I say 10 to 15 hours per week. It's not always that amount, and we don't say every week you have to give that.
Actually,
it's just
that's something probably worth asking Shanti. How do you actually find? No,
we
write this on slides all the time. Is it in any way true?
No.
Well, yes. So this is doctor on the program, doing very well on the program, and she would say that that's not true.
What does the average week look like for you, Shanti, in terms of study?
5 to 6 hours a week.
Yeah.
Okay, yeah, it's funny when the university adds up everything you could possibly do and reading all of the supplementary reading and everything else, that's what it comes out as. Yeah, my suspicion is 5 or 6 hours a week is probably right, and it probably ramps up directly before an exam.
Exactly.
Yeah, right.
So yeah, we don't want to scare you off, but in an awful lot of universities, it would take at least 2, maybe even 4 years to do a master's by distance learning or by part-time, and we'll give you the master's in 20 months. So we don't want to sugarcoat it. It's not easy, but it is manageable. So we just want to be very realistic in what to expect on the program, but you will get very strong support and individual assistance. So next, I'll just walk through the modules and what to expect. We start off the first module. The first 6 weeks will be core principles, epidemiology, diagnosis, screening. And as Shanti said, that she has noticed herself in her clinical impact would be early diagnosis. And that early prevention is absolutely essential to managing any NCD, but particularly diabetes. The next module then is treatment, and many of our clinicians say this is the most weighty module of all of the 6 modules in the postgraduate diploma, because we go into all of the treatments, the medicinal treatments and interventions. We look at NCD, the chronic illness model, and you can also cut and paste some of your learnings from your chronic illness model into other diseases like cardiovascular, COPD. We look at glucose-lowering medicines, as Dr. Letchuman said. Once upon a time, it was change your lifestyle and take metformin. Nowadays, there's so many different oral medications and injectables that it's quite staggering. And also, you know, one size does not fit all. So if you've comorbidities, multi-morbidities, and your interactions with certain drugs, you really do have to start prescribing based on the individual that you have in front of you and the patient living with diabetes. So it's a whole new world. So there's a lot to learn in this particular module. We also go into weight loss surgery, and one of the top, he is the head of the Obesity Society in the United Kingdom, is also affiliated with our program. Obviously he is a bariatric surgeon, and we would look at weight loss surgery there. And we look at diabetes in children in that particular module as well. The next one that we look at is self-management, and actually the clinicians enjoy this one. A lot of the feedback we get is that this is their favorite model, because they can use it in a huge amount of clinical settings, not just in diabetes care. It's all about, we teach the clinician how to do a motivational interview, you know, how to really get the patient living with diabetes to feel self-empowered and have a lot of knowledge around their own condition. In the United Kingdom, they'd use a phrase, no decision about me without me. And it's very important for the patient to fully get on board and be part of the solution. You will be with them maybe 3 times a year for maximum, you know, 3 hours maybe, if not less. And they've 8,700 hours where they're by themselves managing this disease. So it's very important that they understand and take ownership and responsibility, and you help them and guide them in that. So that module 3 is very popular with our clinicians. Module 4 is obviously the complications, microvascular, retinopathy, etc. And module 5 is macrovascular. And then we finish off with special situations like Ramadan and Hajj and religious fasting. Obviously, the patient living with diabetes is exposed to both hypo and hyper during a fasting period. So it's very, very important to be prepared and adjust medications accordingly. We look at travel, mental health. You're 3 times more likely to have mental health challenges if you're a patient living with diabetes. And we look at older people, comorbidities, multi-morbidities, etc. So that's what to expect in the 12-month postgraduate diploma. If you aren't sick of us, and if you haven't run out of steam, you can progress to the MSc after that. So the MSc is an additional 2 modules. The first module is a research methodologies module, where you will essentially select the topic that you're going to do in your professional project. And you will be doing understanding of critical appraisal and research methods, your quantitative and qualitative analysis. And then you do your professional projects. This one we're very excited about, because in many masters, you will just do a thesis. You do a research thesis, which will gather dust and sit in a library in a university, never to be read again, except by yourself and your supervisor. So what we've decided to do as the outcome and what you should be delivering in your MSc is your professional project, where you will do a conference, medical conference poster presentation, and also a journal submission from, I suppose, in line with ADA guidelines in terms of submissions. So we would ask then that you submit that journal as submission to a global, or national or global, I suppose the BMJ, or a journal of international repute, with the outcome and anticipation that you will be published. So the fact that you can be published from your MSc will really lend a lot to your own biography and your own CV, but also from the wider point of view, and from our own point of view, it gives back to the diabetes research community globally, and that's really, really important. So it's a win-win-win, and we're very proud that that will be your output from the MSc. So how does the actual program work? We start with workshops now. Normally these are face-to-face workshops in KL, and we fly our international faculty to meet you in person. This is not going to happen because of COVID-19 at the moment. So we are going to swap our workshops into an online environment as well. Hopefully we will all meet in person in November for the second workshop. That would be, it's scheduled to be on the 28th and 29th of November. But normally we do them face-to-face and we kick off face-to-face, but please be reassured that you will be at no disadvantage and the workshop will be done online to an exceptionally high level. The workshop really gets you comfortable with the online learning environment and how to navigate it, how to set yourself up correctly and get you to know your tutors very well. And also we do in the face-to-face workshops, we will look at, you know, your pump therapies, your insulin pens, your interpreting retinopathy scans, but we will make sure that you are at no disadvantage whatsoever with the online alternative. We do have weekly discussion forums. So every week your tutor will throw out a particular case study and which will cover your learning outcomes for that week. And you'll be looking at a particular case with particular HbA1c or blood pressure, and you'll be talking about how you would treat that individual. And at the end of the week, it culminates in an online tutorial. These are usually done in the evening and at a time most convenient to the clinicians in your local area. We understand, we like to say that these are mandatory, but we understand that you have such a busy life that sometimes you will not be able to make these online tutorials. And in those circumstances, they're all recorded and you can download it at any time you want and watch it later. And it's just like this, it's a live Zoom session where you will be talking with your tutor and the rest of your peers. And it's not didactic, it's not the tutor knows best, it's very much peer discussion where you learn as much from your clinicians and your peers as you would from your tutor. And I think when you talk to the students on the program, they really enjoy that interaction and it makes you feel like a real collegiate environment and that you're not studying in an isolated session, and you get to know your student and your fellow peers very well. We also have continuous assessment. So at the end of each module, have a 2,000-word essay to submit. Don't panic too much. We do give out the topics for the essay very early, usually at the starting of each module. So you have the whole 6 weeks and the additional 2 weeks to do that essay. So you've 8 weeks to do the 2,000-word essay and you've one for every single module. At the end of each semester, you also have online exams, or semester exams. So they're done in an online proctoring session, predominantly MCQs, and you can do them from the comfort of your own home as well. So you don't have to go to an exam center. So it's very convenient. So as I said previously, it's a very unique online experience. We talk an awful lot about individual case studies and nuance them to your local region. And it's very navigable and easily digestible information. As you can see here, this is a particular case study from one of our students in the GCC. And this is Mohammed Fargali, one of his videos, and he would be, as I said previously, a renowned expert in diabetes management in the GCC. And just like we're talking now, on Zoom, you will have your online tutorials every single week for 1 hour.
I think it's fair to say that the online tutorial element is probably one of the most valuable elements of the program, where you come together with your group every week and you really get to know them as a group. I mean, Shanti, in terms of the different elements that Rebecca's gone through there, how did you find the getting to know a group that you only meet online really regularly?
Actually, we formed our own WhatsApp group. So when we used to have interesting cases, we'd discuss. If we had any doubts, we'd bring it up on the weekly sessions and discuss it with the tutor. So it was really helpful.
That's brilliant.
Yeah. The sense we have, from 9,000 kilometers away is that there is an actual sense of camaraderie in the group. You've all gotten to know each other really well.
Yes, we have. And we also get to learn from each of them, because each of them have different experiences.
Yeah, absolutely.
That's wonderful.
Yeah, this is sorry, Rebecca.
Yeah, just this impact slide. We have done a few analysis with our students in the past in terms of impact and output from the program. The most important is the quality of patient care, or the clinical impact in terms of initiating insulin, and prescribing SGLT2s, GLP-1s, and recognizing mental health issues in young adults with type 1 diabetes. All of that is hugely improved in terms of confidence levels of our students and our clinicians on the programme. Then, therefore, the quality of patient care in terms of a large positive impact has been achieved. So we're very proud of that. In terms of your career, there's some positive impact. We see an awful lot of our clinicians have gone on to open their own diabetes clinics. They've gone on to be national leads in diabetes committees and therefore steering their own governmental and national strategy towards NCDs and diabetes management. We've seen the reputation with colleagues in the community becoming a diabetes expert within your own local community, and understanding, I suppose, research and outputs and clinical trials results in terms of the positive impact and being able to read them with confidence. And so that is what the students are feeding back to us as their major impacts and, I suppose, the results of doing the programme. Just a synopsis, the administration of support with programme leaders, tutor network, mentors and supervisors, the course management team, and technical support. So we do have, the beauty of being an online programme is we have analytics. So when a student is going below a mean average, that can be flagged on our system in terms of page views and tutorial attendance and submissions, etc. So if a student is struggling or falling below the mean average, we can reach out and give additional support. And as a result of that, our attrition rates and our dropout rates are extremely low. And we're very, very proud of that because we want to make sure that you're well looked after. And if you are struggling, we have, we can make exceptions and extenuating circumstances to make sure that you're looked after and you stay on the programme. We've had clinicians who've been pregnant, have gone maternity leave, etc. And we will work around that to make sure that you are looked after. So the entry requirements and what we ask for on the application form is evidence of proficiency in English language. It doesn't have to be IELTS or TOEFL. Obviously, all Malaysians are perfect at English. And so sometimes we ask for a 5-minute recorded call with our academic affairs team, and that's submitted. And it's just an English language proficiency interview, and that's submitted to the University of Warwick along with the rest of your documentation. So you do not have to have an IELTS or TOEFL. Full employment in a medical practice throughout the duration of the programme. And we look for your degree, your MBBS or your MD, or your degree, your full bachelor in a medical background or medical discipline. A personal statement, which is 500 words outlining why you want to do the programme and your motivations for doing so. An academic or employer reference letter, and a photo ID. The photo ID is not a selfie, it's actually a legal document, whether it be your passport or your driving license. And as I said, limit places are available. We don't just take anybody. We do limit because we pride ourselves on a lot of one-on-one tuition and care with our students. So the programme fees, the most important of the lot are the programme fees. So the fee for the postgraduate diploma globally across the world is €7,500, which is 35,000 Malaysian ringgit. And the Master of Science is 21,000 Malaysian ringgit. We understand, and we've been in Malaysia for a number of years now, that that's just too much money. And it's too challenging for our clinicians to be able to reach those prices. So we worked with the Malaysian Medical Association to bring you a very considerable bursary, and it only applies to Malaysian clinicians. It does not apply anywhere else in the world.
Well, so clinicians based in Malaysia, you don't have to be a Malaysian citizen.
Exactly, exactly. So essentially the rest of the planet will be paying 56,000 Malaysian ringgit for the MSc, and you will be paying, essentially it would be 37,000 Malaysian ringgit. But you don't have to make up your mind about doing the Masters straight away. You can start on the Diploma, which would be the 23,000 Malaysian ringgit. And then that's also very flexible payments. You can pay by semester or you can pay by monthly installments, so you don't have to pay it all up front or anything like that. So all we ask is the 500 deposit, €500 deposit, which would be 2,400 approximately Malaysian ringgit, to secure your place on the programme for now. And then we can set up a monthly subscription plan for you to make it easier. So it is quite digestible and easy to manage. And we do, if you're not sure about doing the master's, you can start off with the postgraduate diploma. Finally, we have 300 plus students from over 25 countries on the program, and that's rising by between 200 and 300 every year. So we're very excited about that. We have 88% student engagement, which is really high for an online program. 100% positive program support. That's the feedback we get from the students on our questionnaires that we send out to them. And it's a 92% pass rate to date. And that's genuinely not because we are easy markers. It's because the clinicians are just so dedicated. You're professionals, you're doing the program for the right reasons, and you understand how important it is. So that's a reflection of how good our students are, not that we are easy markers. So that's the summary. So it's a 12-month for the postgraduate diploma, or 20 months for the master's, so an additional 8 months, 20 months for the two programs combined. The next intake is at the end of April. Well, actually, we will be moving that now to the end of May. Isn't that correct, Dermot?
Yeah, it's going to start, the module 1 will start the weekend of the 29th of May, thanks to COVID-19.
Thanks to COVID-19, I should have changed that. Yeah, so it'll be after Ramadan that we will commence the program. And as I said, we have local support and endorsement by the Malaysian Medical Association, the Ministry of Health, and NADI. It is part-time. You can do it at your own pace, your own time. And it's very engaging, and our clinicians really do enjoy it. So I will open to the floor now for questions, and you probably, Padma, I don't know if she's still on, Padma and Shanti are two students, existing students on the program that you might want to ask questions to as well. And you're very welcome. And if you just want to unmute yourself, bottom left-hand corner, to unmute and ask a question. And if you're feeling very shy and you don't want to ask a question, you can also chat. There's a little chat button at the bottom of the screen as well, where you can ask questions. So open to you guys. Do you have any questions for us today?
Yes, I have a question.
Sure, shoot.
My name is Sophia. Okay, from your presentation, right, you said the program is more for clinicians, but I'm not a clinician. I'm just more of a researcher. I have a PhD in pharmacology. So can this program also apply to me? Because my research is geared towards diabetes and osteoporosis, and I just want to learn more. So I don't know if this program is suitable for me or not.
We have to see your undergraduate. You pharmacology, is it, Sophia? And your undergraduate as well?
My undergraduate is in biotechnology, and then my master's and PhD is in pharmacology. So I don't know if this is suitable.
What we would do is we would take your documentation and bring it directly to the University of Warwick for review, and we'll get clarification for you very quickly.
Yeah, so some of the content in terms of the medical side of it may be beyond what you've done. It may be fine. It may be they might think it's a jump, but yeah, we'd absolutely just look at that individually.
Okay, all right, sure.
There are a wide mix of professions represented on the program. Our responsibility is to make sure that someone that comes onto the program has a very good chance of passing and getting out the far side qualified. So we'll look at anything like that individually very happily for you.
Okay, all right, sure. So who do I have to contact to get this checked? I've been in contact with James. So
yeah, James can reach out to you after, Sophia. And if you can just send your qualifications, your certificates to James, we will check with you.
Okay.
No problem.
Okay, all right, sure. All right, thank you so much.
Brilliant. Thanks,
Sophia. Zenat has another question on chat. For non-members of the MMA, are they eligible to get the discount? Yes, we have agreed that all persons resident in Malaysia will be entitled to the discount. So you don't have to be an MMA member.
Yeah, it started off that the primary interest in the program was from MMA doctors, and that quickly kind of expanded out. So yeah, it would be very unfair not to give that to everyone else.
And is that your question? Is there is an MCQ examination at the end of each semester? Do you need to pass the examination before we can proceed to the next level?
So the short answer to that is yes. There's there's an essay at the end of each of the 6 modules, and then there's an exam at the end of each semester. The exam is worth 30%, and the exam covers the 3 modules, and the exam covers 30% of it. The exam is not something to fear at all. They're pretty straightforward. The pass rates on the exam are usually above 90%. It's there because universities like exams. It's not there in any way to trip you up. And 70% of the grade goes for the essay. So yeah, the exam, you do it online. The format is usually short little case scenarios, and then ask about, what would your diagnosis be, or what would your next line of treatment be, or something like that. So very much based in the content that you will have discussed in depth on your tutorials. The other question then, what day do we usually have the tutorials? It's usually a Thursday evening. It's about, is it 7:30 or 8 o'clock Malaysian time, Shanti? It's usually...
Yeah, around 7, 8 o'clock at night.
Yeah, so, that's obviously for someone like Let, she's doing it in the evening. For your tutors that'll be based in Ireland or the UK or the Middle East, they'll be doing kind of lunchtime to afternoon, so that it's positioned after work, after a normal work day, if there is such a thing. So it's in the evening.
And how many do we have in the intake globally? We have 300 now per annum across the whole world, but in each region it's usually 20-25 students we take on, maximum 25. So that's what we normally take on in Malaysia, between 20 and 25.
The group that there's 34 participants on this call now, and unlike this call where we've given you a lot of information, the tutorials are very much a back and forth conversation, and you can see the way Rebecca and I and Shanti are able to just kind of speak over each other and chat as if it was in a room. The tutorial discussions every week are very conversational, and for that to work, it needs to be a small enough group. So that's the reason for the group sizes that we have.
And is that, you asked about a formal graduation. Normally we do have a really nice ceremony in the MMA building, and across the world we've nice ceremonies to give out the certificates. With COVID-19 at the moment, we probably won't be having a ceremony, but by the time you guys are finished the program, we would hope and pray that we'll be back to normality, and we should be able to do a ceremony again.
So yeah, as Rebecca said, we would do a ceremony in the MMA. The other option that people can do is they can come to Warwick for the full university ceremony if anyone wants to go 9,000 kilometers to do that.
Some of our GCC doctors do.
Some of the Middle East doctors do it, and it's a lovely occasion. But yeah, there will be a formal ceremony after COVID-19. Yeah, the certificate recognition worldwide. So Warwick is a top 10 university in the UK. It's considered, depending on the particular ranking that you look at, it's top late 50s to early 60s of all global universities worldwide. The qualification, it sits on the UK's national education framework. It's called the QAA framework, and it sits there. They have 8 levels. It sits at level 7. Level 8 is a PhD. Level 7 is a postgraduate diploma or master's. So it sits on that framework and is absolutely recognized world over. So yeah, it'll be as recognized in the United States as the United Arab Emirates, as Malaysia, as the UK. It's recognized everywhere.
You were saying when does the master start for us, actually?
The masters will same date, actually. It'll start at the end of May. I think it's the very last week in May the masters will start. And the format of the masters basically will be 8 weeks of a taught module in the same way that you'd be used to the other taught modules on research methods and defining your professional project question. So that'll be a combination of tutorials in the normal style, reading the materials, and then effectively defining what the project that you're going to carry out is. And there's a huge range of project types that you could choose from doing something within one clinic in terms of an audit and impact, or some people are going to do something that's very literature based, that some will do stuff that's very kind of public health epidemiologically based, others will do a more traditional research project. So it's defining what that will be over the first 8 weeks, and then effectively you present your research proposal. So 20% of the MSc grade goes for that. And then at the very end, so then you're carrying out that project with a supervisor on a one-to-one basis. And then at the end, you present the two things that Rebecca spoke of, which is the conference poster presentation and then the actual, the journal article. And, throughout we're very lucky. Our medical editor used to be the editor-in-chief of the Canadian Medical Journal and is one of the editors on the British Medical Journal now. And he's going to be giving lots of guidance on how to actually get your research published. What do editors want to see? How to, what's the best opportunity to get stuff into the public domain? Which, ultimately is, that's the impact that we want to see. So yeah, and the 8 months is, that's the maximum. We think some people might do their projects slightly quicker. Once that 8-week initial part of the module is up, then it's very much, you'll do your professional project and everyone will do it at a slightly different pace. So you may be ready for submission, a couple of weeks before Padma might be, or vice versa.
One other question there, can we prepare our research way before we proceed to MSc? Yes, of course, in theory you can, but obviously there is a structure, and you would only be starting that structure when you join the MSc. But in terms of deciding on your topic and begin to do some of your research and your your qualitative and quantitative analysis, of course you can get cracking.
You can certainly make life easier on yourself if you want to front load some of that.
Yeah, but obviously we're very aware that you are busy clinicians. You have huge workload and you have family commitments and you have everything going on. So we'd be conscious not to overload yourself as well, because you've enough to cope with.
Yeah.
I just want to ask, even for MSc, we have 2 intakes, is it? Or it's only 1 intake for the year?
It'll be 2. There'll be an MSc after each program, effectively. After each 12-month period, the MSc will start. So the first round of the MSc will start now in at the end of May, and then when the folk that started last October finish up in October, November time, their MSc will start then.
Okay.
Yeah. So Jamid, would our results be out by then?
You will. They might not be. Short answer: they might not be exam board ratified, but you will have. You'll have the informal results.
Right. Okay.
So, there's one other question there. Ashani, who's an ENT surgeon.
Yeah, absolutely. No reason why that wouldn't be suitable for you. The particular research topic, I mean, my guidance on that is, choose something that's obviously of interest to you and that is of relevance to whatever sector you're working in. So, if you're working in ENT, you might want to think about how patients with diabetes interact in your clinical setting, or what referral pathways look like. There's a very broad range of types of research and topic areas that you could look at, and I think that's what the first 8 weeks of that module is going to do, is going to help you define exactly what area you want to look at.
And we do, of course, have an individual mentor for every single master's student. And as Dermot said, you will have a one-on-one discussion with your mentor in the final module on a weekly basis. So you'll get to know that individual very well, and they will steer you very, very closely. And you will be given submissions to your mentor on a weekly basis as well.
You'll also have access to a statistician if, like the rest of the sane world, you massively fear and hate statistics.
So any other questions, guys? This session has been recorded, so we will send you out a recording if you're very bored and want to watch it again. And just to let you know that James and Mark and our education advisors will reach out to you after this session in the next few days to just give you a call, see if you got all the information that you needed, if you need any more information, and if you want to proceed to application.
And thanks so much, Shanti and Padma, for coming on. Really appreciate
it. You're so good. Thank you.
Oh, you're welcome.
Thank you.
You're so good.
Thank you.
We really appreciate it.
Thanks a million, guys.
Thanks for your time. Take care.
Okay.
Okay, see you. Bye.
Good night.